of October 16th, 2024 to order. Melissa, if you could please call roll.
Chair Shelley Bailey.
Present.
Vice Chair Amy Burns.
Present.
Dan Hartung.
Present.
Lori Hoagland.
Present.
Robert Judge.
Present.
Chris Lehman.
Here.
John Murray.
Melissa, I believe he has an excused absence.
Okay, thank you, Chair Bailey. Dan Kennedy.
Present.
We have a quorum, Chair Bailey.
Thank you. I would now like to ask if any board members have any declarations of real or perceived conflict of interest that you'd like to share today. Okay, well, with no one declaring any real or perceived conflict of interest, I will move forward. Oh, Mr. Robert Judge, your hand is up. You have the floor.
Yeah, sorry, my hand movement was slow this morning. I just wanted to alert the board and the public that as an employee of Moda Health, I want to recognize that there may be a potential conflict of interest on certain items as they come up on the agenda. And if and when they do, I will disclose that there's a potential conflict and recuse myself if necessary.
Mr. Judge, thank you for that information. Before I advance in the agenda, does anyone else have any real or perceived conflict of interest that they'd like to present today? All right, well, we'll move forward with the agenda. I would like to ask my fellow board members here today if anyone has any changes to the draft meeting minutes from the October 22nd, excuse me, how about the October 2nd, 2024 meeting? Does anyone have any changes that they would like to propose? Okay, well, without having any amendments to the draft minutes, I would like to ask for someone to provide a motion and then a second to approve the minutes.
Chair Bailey, this is Dan. I move for approval of the minutes.
Thank you, Mr. Kennedy. Do we have a second?
This is Lori. I move for second.
Thank you. Melissa, could you please call roll for approval of the minutes?
Dan Hartung.
Aye.
Lori Hoagland.
Aye.
Robert Judge.
Aye.
Dan Kennedy.
Aye.
Chris Lehman.
Aye.
Vice Chair Amy Burns.
Aye.
Chair Shelley Bailey.
Aye.
Motion passes.
Thank you, Melissa. I would now like to call on Executive Director Ralph Magrish to provide us with a program update. After this update, Ralph will pursue helping us facilitate a discussion and a presentation related to the DPT program and an introduction of DPT staff. Welcome, Ralph, and you have the floor.
Thank you so much, Chair Bailey. Good morning, everyone. A lot going on at DCBS these days. First, there will be a Rules Advisory Committee tomorrow on updates to rules for the Drug Price Transparency Program. That is a continuation of previous Rules Advisory Committees. Just to note for folks interested in that, while that RAC, or acronym Rules Advisory Committee RAC, has already been seated, this is, of course, an open public meeting. Information about viewing that meeting can be found on the DCBS rulemaking webpage. That Rules Advisory Committee begins promptly at 10 a.m. tomorrow morning. Next, DCBS will also hold its first Rules Advisory Committee on the new Pharmacy Benefits Manager licensing requirements created under House Bill 4149 from last session. That RAC will be held on Wednesday, October 30th from 1 to 3 p.m. A web page is under development now, and information should post in the next week or so on that. Meeting materials will be posted there, and the meeting will be recorded and uploaded for public viewing. Oral public comment will be built into that agenda, and written comment opportunity will be available once the notice of rulemaking has actually been filed. Next, I'd like to share a save the date with you, and we will get information up on our website as well in the coming weeks, but that is for the annual Drug Price Transparency public hearing. It will be held on Wednesday, December 4th from 10 to 12:30 in the morning. It will be a hybrid meeting for the first time, and those wishing to attend in person will be welcome to do so in Salem at the Labor and Industry Building on the Capitol Mall, and others welcome and invited to join online. That program and presentation itself will be a review of highlights of data and findings from information collected from manufacturers, carriers, and now PBMs. We'll also hear about the program's policy recommendations to the legislature and hosting 2 separate panel discussions this year. Those will be moderated by Oregon legislators. We have commitments thus far from Representative Rob Noce, Representative Emerson Levy, and Senator Deb Patterson, with several invitations still outstanding. Couple interesting topics and discussions that I'll put on your radar for that. First is one on drug advertising, subject line, who really pays for drug advertising, and is what you see what you get? How do these expenses affect drug cost in the United States, especially considering that most countries don't allow direct-to-consumer advertising? We have invited a number of panelists and speakers there. We're very pleased to announce our confirmed presenters. Dr. Michael DiStefano, he is an assistant professor of clinical pharmacy outcomes and research at the University of Colorado. Dr. Stefano is well published in the area of direct-to-consumer pharmaceutical advertising, has been published in the Journal of Medical Affairs and Health Affairs. Last year, he co-authored an article with Dr. Jerry Anderson, who's a member of the Maryland PDAB, and others, titled "The Association Between Pharmaceutical Product Characteristics and Manufacturer Spending on Direct-to-Consumer Advertising." We're also very excited that we will be having someone join us, Sneha Davi. Sneha is the executive director and founder of Generation Patient. That's a patient advocacy group that facilitates events, online programs, and advocacy initiatives for young adults with chronic and rare conditions. Generation Patient does not accept money from drug manufacturers or insurance companies, and Sneha will speak to the increasing infiltration of pharmaceutical companies advertising on social media, especially Instagram and TikTok. And then we are pleased to also know that we will have participating with us the Perspectives of Pharma, presented by Daria McGrew and her association, and Charlie Fisher from the Oregon Public Interest Research Group, a nonprofit that advocates for consumers and the public interest of Oregonians. Next, we will have a panel presentation on drug rebates, titled "Why Are Drug Rebates Necessary and How Do They Help or Harm Consumers?" Confirmed panelists thus far include Daria McGrew from Pharma, Pat Hubble, independent pharmacy owner of Brooklyn Pharmacy in Southeast Portland, and Jennifer Baker from Cigna. We have several other outstanding invitations, including to PCMA and other entities. So please mark your calendar again for that date on December 4th from 10 to 12:30. And moving into the next introduction of our discussion and presentation from Taryn, I'd like to welcome Taryn Hines, a research analyst from the Drug Price Transparency Program, to report on DCBS data collection efforts on PBM reporting as directed by Senate Bill 192 from 2023 rather, sorry. And that is the same piece of legislation that directed us to develop our upper payment limit implementation plan to deliver. Before I welcome and introduce Taryn, excuse me, it's also worth noting to the board, particularly because we have had some new folks join us this year, that the board did recommend in December of 2023 to the legislature, just prior to the beginning of the 2024 session, to expand PBM reporting. And I'd like to read and remind the board what the board said in our recommendation to the legislature at that time. Transparency laws can impact corporate behavior, but the effect is often attenuated. However, minimal public information about PBM business practices and pricing models make state regulation of PBMs difficult. Collecting additional data could generate more insight into the role of PBMs in drug pricing and support the development of more substantive policy recommendations concerning PBMs in the future. So to that point, I'd like to think that the legislature heard us when it adopted that particular piece of House Bill 4149 last year that directed DCBS to begin collecting the following information from PBMs beginning in 2025. And those additions were the total dispensing fees paid to the pharmacy benefit manager and to pharmacies, the total administrative fees obtained and retained from manufacturers and carriers, and money obtained through spread pricing, pay for performance, and similar means. With all of that said, I'd like to welcome Taryn Hines to share with you the output and results of our 2024 PBM data collection efforts. Welcome, Taryn.
Hello, everybody. Can you hear me?
Yes.
Yes.
Yes. Okay. Fantastic. Thank you for that introduction, Ralph. My name is Taryn Hines. I am the research analyst for the Drug Price Transparency Program, a part of the Division of Financial Regulation here in Oregon. And today we'll be talking about pharmacy benefit managers' data reporting in Oregon this year. Melissa, if you could, next slide, please. As required by Senate Bill 192, enacted in 2023, the Drug Price Transparency Program collected 4 aggregated data points from 59 pharmacy benefit managers, also known as PBMs, doing business here in Oregon. A quick summary of those 4 data points are below. The first being the total manufacturer payments, fees, price protection payments, and any other payments from manufacturers related to managing benefits for insurers issuing health benefit plans in Oregon. If I use the term rebates, this is what I am referring to. The second being the amount of payment passed to insurers issuing health benefit plans in Oregon. The third being the amount of that payment passed to enrollees of the health benefit plans in Oregon. And finally, the fourth being amount of that payment retained by the PBM as revenue. We collected this information for the first time this year for operations in 2023. The deadline for reporting was June 1st of this year. Melissa, next slide, please. So many of our 59 PBM companies doing business in Oregon were exempt from our reporting requirements for a variety of reasons. That was 41 of 59 PBM companies. The remaining 18 gave us manufacturer payment data. Those 18 companies are listed below. For those 41 exempt companies, the main exemptions to reporting were ERISA plans. These are Employee Retirement Income Security Act self-funded plans, or they were workers' compensation plans only. They had no covered lives in Oregon. They were either Medicare plans or they were a Medicaid program. Melissa, next slide, please. Per ORS 735-537, the Drug Price Transparency Program published the aggregate sum of each of those 4 data points described previously. Those are below, and I'll get into them just in a second. So across the 18 reporting PBMs, the total rebates and payments from manufacturers was just shy of $287.6 million. Of that amount, $283.7 million was passed to the insurers, $2.2 million was passed to the enrollees, and $1.6 million was retained as revenue by the 18 PBMs. It's also important to note that ORS 735-537 prohibits disclosure of PBM-specific data. What this means is that we cannot publish data or analysis where a PBM's data could be connected back to a specific PBM. Everything must be done in aggregate. Melissa, next slide, please. Again, there were 3 primary modes of distribution for these manufacturer payments. One being an amount passed to the insurers, the second being an amount passed to the enrollees of the pharmacy program, and the third being an amount passed retained by the PBM as revenue. We're going to break those 3 figures down in the following graphs. Melissa, next slide, please. As stated, $283.7 million was passed to the insurers. This ended up equating to 98.66% of all of the rebates received across 18 PBM companies reporting to us this year. That $2.2 million that was passed to the enrollees of the program equated to 0.78% of the total manufacturer payments. And that $1.6 million retained by as PBM revenue equated to 0.56% of the manufacturer payments received. Melissa, next slide, please. We were able to push that analysis a little bit further, keeping everything once again in aggregate. What we did is that we took those 18 reporting companies, we ranked them by rebates received, which means the companies, the largest companies receiving higher amounts of manufacturer payments ended up at the top of the list. And the smaller companies receiving smaller amounts of manufacturer payments ended up at the bottom of the list. We then took this list of 18 and divided them into 3 groups of 6 companies each, and independently studied the distribution of the payments in those groups, similarly like we did previously with all 18 companies. So what we found were that the top 6 PBMs passed 98.7% of their rebates onto their insurers, leaving 0.78 to be passed to their enrollees, and less than 0.5% of those rebates were kept as revenue. In contrast, the middle 6 PBMs retained 25% of their manufacturer payments as PBM revenue, leaving 75% to be passed to insurers and 0 to their enrollees. Keeping with the trend, 30% of the manufacturer payments received by the bottom 6 companies were retained as revenue, and 70% was passed to the insurers. Again, 0 passed to the enrollees. So what we've been seeing here is that these smaller PBMs are retaining higher percentages of their manufacturer payments as revenue. Next slide, please. However, if we look at the gross spending terms of these companies and these groups, we see that the top 6 companies are working with hundreds of millions of dollars in rebates, where the middle 6 companies are working with hundreds of thousands of dollars in rebates, and the bottom 6 PBMs are working with tens of thousands of dollars in rebates. We'll illustrate this a little bit more clearly in the next slide. Melissa, next slide, please. So again, keeping with this idea of 3 groups of 6, we found that the 6 largest PBMs received $286.7 million in manufacturer payments, while the middle 6 PBMs received $824,000 in manufacturer payments, and the bottom 6 PBMs received less than $35,000 in manufacturer payments. The next slide illustrates those 2 smaller categories more visually, a little bit better, more visually. Melissa, next slide, please. So again, here is the visualization of those 2, but it's compared to what the largest PBMs are collecting in terms of manufacturer payments. Melissa, next slide, please. So again, this was the first year we collected and analyzed this data. So naturally, there are lessons learned and things we are excited for on the horizon. Some of the lessons we learned were that, again, 41 of our 59 PBMs were considered exempt from our reporting requirements. We believe our program should be granted additional authority to make sure we're not missing any of this important information that we're trying to analyze. The second being that data could not be validated independently by our program. This may change with PBM licensure laws going into effect 2025. And as Ralph mentioned, on the horizon, beginning in 2025, DCBS will collecting the following data points as required under House Bill 4149. The first being the total dispensing fees paid to pharmacy benefit manager and to pharmacies. The second, the total administrative fees obtained and retained from manufacturers and carriers. And finally, the third, monies obtained through spread pricing, pay for performance, or similar means. We hope this will be more encompassing of the data that we are trying to collect. And finally, we come to our question slide. Melissa, next slide, if you could, please. So I'll just open this up to anybody. I'll look for hands. If somebody could help me monitor the chat, I'd be appreciative. Amy Burns.
Hi, that was really interesting.
Thank
How many lives are we talking about here?
We did not collect, that was not part of our collection. There were 4 data points mentioned, the rebates received and then where those rebates were passed through. We could, that's about as much as I can answer that question. We can, I believe, connect some of this data to some insurance companies, but this information was not collected this year.
Okay, and then could you maybe expand on the why so many were exempted?
It was I was not the one to follow up on these exemptions, but we worked with Oh, sorry, I just thought I heard somebody saying something. Ralph, maybe if you could jump in.
Or you're muted, Ralph.
Thank you. Apologies. Melissa, if you could bring up the slide that had the list of exemptions.
Sure, should be number 3, I believe.
Yes, I'll do that.
Thank you, Melissa.
Thank you. And Melissa, do you have ability to promote Sophia Para to a speaking role as the program coordinator for the transparency program? I think she may be able to.
She would be able to
Yes.
answer this question a little
Okay,
bit more
let
than
me
I
get-
could.
I will
Great.
Sure.
I will find Sophia.
Fantastic. Thank you, everybody.
And just one last thing while we're waiting for that.
Mm.
So would you, because when I was looking through this and the ERISA, et cetera, I
Mhm.
mean, so that ruled out all but 18
Correct.
but that are working, they're doing business in Oregon. I'm confused about the no covered lives if they're doing business in Oregon.
S-
And then would you qualify, like, would you say that this was mostly then like employee group commercial plans if like you're exempting Medicare and Medicaid?
I think this is commercial plans. I defer to Sophia Para if she is in.
And I'm not certain that I can
Yeah,
speak
Sophie,
about
and if I can welcome Sophie, go ahead.
Yeah, sorry, I'm Sophia Para. I'm the Drug Price Transparency Program Coordinator. And we basically tried to get some information about some of these. We emailed all of the ones that are registered with us. We found that some decided that they really didn't need to be registered with us anymore. It's very odd. Some told us that they had no covered lives in Oregon, and we also were able to confirm some information through another agency that they report to, that some of that was correct. Some of it, we took their word for it, but the ERISA plans and the workers' compensation plans, we were able to verify some of that through the other agency as well. I'm not sure if all of the 59 PBMs that were in our system really needed to be registered with us or not, if some of them just register with all the states and don't really pay the $1,100 fee because it's such pittance to them, that they're making so much ridiculous amounts of money that that's nothing. And so there could be some things with the licensure that comes up next year that clarifies and gets us into a more realistic PBM grouping. And then, of course, we have companies that do their own PBM work and they do not hire a third-party PBM. And hopefully we're getting some of that information through the insurer reporting, because it's insurers who hire them. And I'm hoping that we'll also have a little bit more teeth, and we'll get some more realistic numbers from them next year, especially with those additional information for those who are getting paid directly from the insurer versus retaining manufacturer payments.
And thank you, Sophie. And if we can, I think Robert Judge's hand first, and Dan Kennedy and Dan Hartung, and then we likely will need to move into our next segment on the agenda. So Robert.
Thank you, Ralph and Chair Bailey. I think this is really a very informative first step, and applaud the DPT for collecting this information. Notwithstanding the PBM's reporting that was exempt, I have a couple of observations and then a question. The first is that rebate revenues are significant. The dollar yield that we're seeing there, almost $300 million is really, I understand why it's generated, but it's a very significant dollars. The other conclusion I'm getting, just tell me if I'm right in this, is that rebates are making their way to payers, which is the intent. So the narrative that we've been hearing in the marketplace that PBMs are using rebates to pad their pockets doesn't seem to be demonstrated in the data based upon the dollars that were reported. Understand smaller PBMs may have different revenue models, but is that a correct conclusion, Taryn, from the data?
So it's worth mentioning that to answer your question, yeah, there were 8 of those 18 companies reported receiving non-zero amounts of rebates, and simultaneously reporting zero amounts retained as revenue. Anything more specific, I believe, would violate the ORS, everything must be an aggregate kind of study. I hope that answers your question as much as I can.
Yeah, it does. I mean, at the highest level, I think it creates a counterpoint to what we're hearing in the marketplace. The question I have really is a future statement. As we look to going forward, where we'll get information on fees and other revenue sources from PBMs, will that help inform like the two smaller circles that says, right now they're collecting rebate revenues and holding on to those? It would be interesting to see what the interplay is between rebates retained and fees charged. And
Agreed.
so that analysis I'd look forward to seeing as you collect more data.
Yeah, we hope to expand that to be more encompassing of fees in generality, all the stuff that they call fees.
Thank you.
Anything else, Robert?
No, that's it. Thank you.
Yeah, fantastic. So Dan was next, was it?
Yes.
Take your Dan pick. Go ahead.
Okay.
Okay, I'll go first, Dan Hartung. Yeah. So my question was on your last slide. You had dispensing fees paid to PBMs, and I'm unfamiliar with dispensing fees being paid to PBMs unless you're talking about specialty pharmacies or something along those lines. Dispensing fees are usually at the point of sale, which is a pharmacy-related item.
And Dan, I will take that. This is a bit of an anomaly for me too, in that this is what is in House Bill 4149.
Oh, okay.
Verbatim. So I don't know if that was a Scribner's error or something else. I suspect there will be a need to seek some clarity on that in the future with the legislature and through the administrative rulemaking process.
Great. Thanks, Ralph.
Sure.
Thanks, Taryn.
Yeah, of course. Other Dan.
Yeah, great. Quick question. What's the mechanism that rebates are passed to enrollees?
So again, these were aggregated data points. We couldn't really dig into what they gave us or validate it in any way.
Okay. I don't
Sorry.
know if anyone else.
I'm sorry, could you repeat that question? I don't think I answered it properly.
I would just, you have three buckets, like retained
Sure.
by PBM, passed to insurers, and then passed to enrollees.
Yeah.
And I was just curious if there's any sort of context for because it's almost an equal amount that's passed to enrollees. And so I was just curious the mechanism with which those dollars are actually passed to enrollees.
It's hard again. So yeah, basically it was a black box. We got these data points. It's hard to dig into the exact mechanisms producing what was the sum of passive enrollees, but we did find that really those smaller PBMs aren't passing anything at all to their enrollees, while the larger ones passed about $1.5 million to their enrollees.
Right. I'm kind of almost ignoring those the middle and bottom because it's such small potatoes. But
yeah, agreed. Yeah.
I was just curious. I don't know. Maybe another board member can educate me about how are they rebates paid back to patients or other what the actual mechanism is, because I just don't know.
Sure. Dan, I would broadly say that we were pretty limited by statute in our ability, not just on the aggregation of data and the necessity to de-identify, but specifically the law prohibited us from not just identifying the carrier or any given enrollee, but the price charged for a specific prescription drug or even a class of drugs, or the amount of any rebate or fee provided for a specific prescription or class of drugs. So very limited in the ability to get granular in that kind of analysis. Again, as Taryn noted, and as we mentioned, and hopefully some of this language in 4149 will allow us to gather more holistic information, I guess.
Okay, I don't want to belabor the point, but it was curious to me.
And Chair Bailey, I think you have last question.
Thank you. 2 quick points, Taryn. Thank you for educating us on how our data calls will improve and, modify over time. Two things to mention. I do think legislators were wise in adding fees paid by pharmacies to PBMs because pharmacies are often charged to adjudicate transactions. So I think that was wise of the legislature, and PSAOs and other entities could lean into additional information on that. But I also want to mention, kind of as a counterpoint to what my colleague, Mr. Robert Judge, referenced, I do want to call out that in our data call that we have looking at the past, we don't have rebate data from affiliated entities of PBMs. I know as we move forward, we are going to be doing, more enhanced visibility of some of that, but my perception that we were kind of leading to with Mr. Robert Judge's comment was that that I guess we're not mentioning the fact that affiliated entities do receive rebates. And when you look at the DPT data, it might be perceived that some of the smaller PBMs are taking more of the rebate and things in the ecosystem. But in fact, that is because we are missing some of the data from the larger PBMs related to affiliated entities. So I just wanted to be on the record mentioning that.
Yeah. We hope to really expand what we're asking for and what we're collecting the next few years. Agreed, to be very encompassing of this very important data that we're now trying to get our heads around.
Taryn, thank you so much for the presentation today.
Thank you, board. Thank you, public. Appreciate it.
Taryn, thank you for presenting today. So we are now going to be moving to our Senate Bill 192 upper payment limit draft report. At the October 2nd, 2024 meeting, board consultants Myers and Stoufers presented concepts for implementing an upper payment limit related to the board report to submit to the Oregon Legislature as required by Senate Bill 192. Board members discussed concepts and provided feedback. Today, the board will continue to review the proposed report and provide additional feedback on the draft report. The board will consider the final UPL report at the November 2024 meeting that will be presented to the Oregon Legislature in November. I now call on Ralph Magrish, Executive Director, to start the conversation. I guess I do want to interrupt myself to also mention that we will take a 5-minute break at approximately 10:45, so everyone can mark their calendars for that. But Ralph, you have the floor to help us start the conversation.
Okay, thank you, Chair Bailey, and this will be brief, and then I will speak again and help facilitate throughout this conversation. But as we have a number of new board members over the last year, I thought it was important to give a quick history of how we got here for folks. Reminding you that in 2022, as part of the board's inaugural policy recommendations to the legislature, the board itself asked for authority to the legislature to set upper payment limits for state and local government purchasers. At the time, the legislature did not approve that request during the 2023 session. It did think this issue was important enough to the people of Oregon to direct the PDAB in Senate Bill 192 to develop a plan for establishing upper payment limits for drugs sold in this state that are subject to affordability reviews. I will also note that that report was actually due to the legislature in September, but because of our decision to expand outreach to additional constituents beyond those prescribed in Senate Bill 192, we thought it was the right thing to do in expanding that and do so. And we advised the legislature of our intentions and the ultimate delivery being following our November meeting. So that is the timeline and chronology and history for folks that have joined us this year. And we will go forward, and I can introduce Linda Wyant from Myers and Stouffer. And just to level set for folks, we anticipate that Linda, Chair Bailey, and myself will all kind of co-facilitate this discussion with the board. So if I can welcome you, Linda, thank you.
Thank you, Ralph. Appreciate that. And thank you, Chair Bailey, for letting us walk through this report today and helping to guide the conversation. So thank you, board members, for being here, and good morning to everyone. So with that great background in mind, what we are here to do is talk about, as Ralph mentioned, the first draft of the board's report. and get your substantive feedback. So where does it reflect your thinking? Where does it not? Are there things that you want to add or change? And what are those? We hope that we captured your comments and thinking from the first meeting. And so of course today, as I said, I want to hear substantive policy areas where you have ideas and concerns so we can get you an updated draft to review. And I believe, Ralph, certainly correct me if I'm wrong, but I believe as we've done in the past, you will get an updated report and you will be able to offer inline edits. And so I do want to give you a heads up on this, that we are going to be rearranging the pieces of the report a little bit, so that it will just look a little bit different to you, not be substantive changes to the language in the report, but it may be rearranged a little, look a little bit different from today's draft. And so just to level set, the plan for today is to walk quickly through the background and the consumer engagement piece, and then begin our work on the plan and the methodologies, which are, of course, probably the most important pieces of this particular document. So,
Linda, if I may interrupt, because
Sure.
I think this will be helpful for the board, and apologies for not stating this before, that as you mentioned that we will be sharing the red line version, Word version with board members later this week. If I may for a moment, just run through that timeline for board so you have that lens as you engage in this conversation today. As Linda noted, today is the time for the substantive feedback conversation discussion. With that said, we will get the red line out to, we will get a Word version out to you, if not tomorrow, on Friday. From there, board members will have until Monday, October 28th to work through those and provide red line comments and changes, revisions back to us as staff. Staff will then take that feedback and synthesize it between October 28th and November 1st. Internally, our communications team will work through formatting, presentation style, etc., and it will be included in the board packet that we'll post on November 12th for board review and final approval at the November 20th meeting for subsequent submission to the legislature. So, Linda, thanks for letting me squeeze that in so folks have that frame of reference of the chronology of the next 4 to 5 weeks.
Absolutely. And thank you. So, Melissa, I think if we will start with the background, we can pull that up. So at the 80,000 foot level, really, this is a description of the board's work, the supply chain transaction, the landscape in other states. And my understanding is we are, the staff is preparing some additional historical perspective that we will place into this report. So we will identify that for you when it comes back. Is there any conversation or any discussion or comments that people want to make on this particular section? Any feedback that you all want to move through? Robert.
I think it's just more of a global comment. And Ralph, I really appreciated the fact that you said a red line version is going to be made available to it, because when I went through it, there's a lot in this document. And I didn't approach today with change this, what about this, with specificity to each section. So I appreciate the fact that we'll have a red line opportunity. And call out areas, at least from my perspective, there where we probably strengthen it or maybe edit elements in it.
Thank you.
Mr. Judge, I do want to reinforce, we welcome red lines from everyone on the board today. I do want to make sure substantive conceptual ideas or additional ones that type of discussion we do focus on during today's meeting, just so that all board members have the benefit of hearing.
And Chair Bailey, if I can just add to that and kind of put a pin in what Linda said, and that the construct of the exercise today is really, where does this report reflect your thinking and where does it not? So if to that point there are substantive issues that you have here, we would really hope that we can bang those out in the next hour and 5 minutes. So if there are things you're tracking, certainly invite you to float those right now.
Robert Judge, you have the floor.
Thanks. So, globally, when I think about what's the words that were in this document, what's not jumping out to me, especially when we get into the options, is how a specific option will address our mandate, which is to increase affordability for consumers and the healthcare system. I get the mechanics of some of these options, but I was really struggling to see where the value in terms of how it could be applied. So I'd make that just global statement as we look at this document for our next draft.
And Mr. Judge, I think to follow up on that, keeping in mind that perspective that you share, we have essentially two guiding mandates, right? The Senate bill that created our board, as well as Senate Bill 192, that is our guiding language to, related to getting this specific information back to the legislature.
And then, Robert, if I may as well, I think one of the pieces that we took away from discussion several weeks ago, and I think resonates through this report, and if this is, I don't want to put words in your mouth, but if what I'm saying is consistent with yours, I think the mindset that we as staff have begun to conceptualize through working through this report and conversations with you is in fact that the upper payment limit methodology is ultimately going to be a toolbox. And that toolbox there will be a time and a place and appropriate situation for any given tool, and that to contemplate what wrench or screwdriver or pliers or tool might be needed 2+ years from now would be a fruitless exercise, and that constructively to identify tools that will be necessary is the path of this report. So I welcome your feedback and thoughts on that. And again, this is a board-driven deliverable, so I want to be mindful that those are Ralph's thoughts and staff recommendations, but ultimately this is a board deliverable in terms of construct and design. And as Linda noted, 70,000-80,000 feet may ultimately be some of the requisite level of detail in this.
Chair Bailey, can I respond?
Oh, yes, absolutely. My apologies. You have the floor.
Yeah, so Ralph, I agree. The devil's in the detail on these things, and the best that we could do right now is just describe the tool and when you would use the tool and what benefit the tool in its application would give you. And at 70,000 feet, I think we should strive for that.
Oh, and I guess to follow up on that, Mr. Judge, and again, I know you and I have spoke greatly, but I very much encourage our entire board as we move through this to engage in the discussion. I do feel as we go through this, Mr. Judge, as Linda kind of helps facilitate this, I think one thing you certainly kind of see in the documents is that we are, at least the way I read this, kind of to Ralph's toolbox comment, we're not, from my perspective, we're not saying we have one methodology that we think we should use. We've tried to keep it as broad, keeping in mind different tools that we could use at different times, maybe for different drugs, different classes of drugs. And I think that is a significant advancement in our kind of strategic thinking. But that's for later parts of the document, but I did just want to leave that from my own personal opinion.
Okay, so thank you, Robert, for those comments. Did anyone else have anything they wanted to add about the background area, or are we ready to move on to the public engagement efforts? Okay, Melissa, I think we can move to the public engagement section. Just want to see if anyone has anything around this particular section that they felt like was missing or needed to be elaborated upon. This section is really.
Melissa, as you're advancing these slides, can we go back to some of the visual graphics? I want to make sure as a team that we are, okay, sorry, I guess that is just more of a supply chain thing. I just wanted to make sure to Linda's point, if anyone had pieces of the supply chain or things that they wanted to make sure we reviewed or, edited, that we had for that.
Yeah, and I will point out for these particular graphics, we did choose a publicly available source so that we are hopefully we've hopefully chosen something that's a neutral and accurate representation of the supply chain. Certainly does not reflect its complete complexity, but as best as can be done in a graphic that doesn't take up pages and pages, right? So public engagement efforts, this is probably not new to you all. This is a summary of the constituent group sessions, the board's work in July with your constituent panels, and the consumer engagement session. So the information should not be probably new to you, well, except for the new board members. It will certainly be very new to you. But this is information that has been discussed somewhat in the past. And so we will be happy to take some comments.
Mr. Judge, you have the floor.
Yeah, so, I think this section is my takeaway when I was reading about it is be careful as you proceed, be thoughtful as you proceed. And I think that needs to be an element that is, kind of conclusion to this section that says, this is like kicking a hornet's nest. And you got to be very, very thorough, very, very cautious, and very, very thoughtful in terms of how we approach these, because we know that this is a groundbreaking stuff. And while we capture it in each one of the state experiences, I think it would be helpful for our legislature to understand that this is really, really, really complex and groundbreaking and probably heavily litigated territory.
And I do think, Mr. Judge, some of those types of messages are, kind of addressed later in the document. I mean, I would like to lean into the public engagement piece. And also, actually, Linda, I do want to make sure we kind of don't pass over some of the other state information, because I just want to make sure as a board that we kind of see all that. But related to the public engagement piece, yes, Mr. Judge, I agree with you that this is a very complex ecosystem. I do want to mention, just because I personally was involved in every one of the constituent meetings, as was the Myers and Stouffer's team, that we did make a very comprehensive effort to solicit feedback. And again, I know that feedback isn't a one and done thing, and it is an iterative, long-term discussion. But there was great, one of the primary reasons things are delayed was because we did put a lot of effort and time in soliciting feedback from different constituent groups. So I agree with you that there is a whole lot to unpackage here, but I do want to mention that there was great time and effort put in trying to get robust and kind of educated discussions related to, any impacts of proposed changes.
Mm-hmm.
Right.
Dr. Hoagland, you have the floor.
So my question with the public engagement efforts with regard to providers, was there anything that was sent to them email-wise for input, or was it strictly like Zoom meetings?
Dr. Hoagland, I'll go ahead and answer that question because I was involved in kind of creating some of these constituent groups. I would say we did not lean into physicians as much as with hindsight we otherwise would have. My thought process had been that because physicians are actively busy serving patients, that the advocacy perspective, we were going to be able to get some provider insight on, but I do, just kind of being a transparent person, I do think you called out one group of stakeholders that we obviously need to continue to solicit impact from.
And just to expand a little bit more on that too, we We did send out a survey in advance, and we also provided kind of a brief overview document that went out in advance of the Zoom meetings. And then each of the Zoom meetings had a presentation that was given. So at the beginning of the first meeting we had two meetings with each constituent group. So at the beginning of each meeting, there was a more extensive slide presentation given, PowerPoint presentation given, and then a kind of a recap that was done at the beginning of the second meeting. So hopefully that's helpful.
Mr. Judge, you have the floor.
Yeah, just to comment on it, that, I agree that, this was version 1.0 of, outreach to constituents. And I think there's a lot of lessons learned from that process, and gaps in what we did. I noted elsewhere in the document, there was a reference to if there's a desire to kind of seek information from constituents. That's something that may be considered as we think about this report and its submission. I'd ask the board to kind of put some thoughts into that consideration. My perspective is that the PDAB mission could be richer if we had an advisory board made up of constituents that we could tap into for their expertise.
Well, and Mr. Judge, that point is heard, and I think actually is addressed on page 22 related to
only as a concept, not as a
and actually I will clarify that or lean into what you're saying, that from my perspective, when you're referencing an advisory board or patients and provider specific, from my personal perspective, I was going to ask in my red lines to strengthen that language in bullet 4, I think, of page 22, to actually make that one of our recommendations to the legislature, that if there was UPL authority, that there would be an advisory board. So I'm glad you mentioned that, because that was going to be something that I was going to add in my red lines.
I said it more directly than I
was
said.
Implied, but we should not assume anything, right? I do want to mention though, Linda, I can't recall exactly what page in the report it is, but can you in your notes help read for just all my colleagues here what constituent groups we did solicit meetings from? And again, I agree with Robert, this was iteration 1, but I do want to make sure for the record that we do share with everyone what groups we did invest time in making sure that we could hear from.
Yeah, absolutely.
So I took off my head, but I don't want to miss anyone.
It's okay. Yeah, absolutely. On page 17 of the document, Melissa, we actually it's kind of listed across the top of that table is probably the easiest way to see it. The piece that maybe not as clear for those that weren't, partly in the interest of space, the pharmacy groups are combined a little bit more, but for the most part, it's really, well, I guess they're really not. So it's really detailed kind of across the top. So, just for the record, the 340B covered entities, carriers, hospitals, patient advocacy, pharmaceutical manufacturers, PBMs, and then the retail pharmacies, which, as Ralph has alluded to, we did, and Shelley too, we did make some changes. There were some requested changes to the way the focus groups worked. And so while we had retail pharmacies initially identified, obviously, as a very important constituent group, there was a desire identified at a later time to add the PSAOs and GPOs, and then the wholesalers and distributors to the conversations as well. Mm-hmm. So those got added at a little bit later time. As did of course, the pharmaceutical manufacturers and PBMs were added into that sort of second round. And certainly it's, you have identified additional groups as well, and that can certainly be a recommendation, is that either through your advisory council or however you wish to frame it, that iteration 2.0 of constituent group engagement could include additional groups if that's your desire. So we can look for that conversation either now, if you have some thoughts, or within your red line comments too, as you bring them back. And certainly on page 22, the bullet point that we were discussing about, I'm sorry, Melissa, I know we're kind of all over the place, aren't we? That fourth bullet speaks to the advisory council being an opportunity. And certainly it's currently written as, if there is a desire, we could, we may need this. And certainly that language, if that is the desire of the board, can certainly be strengthened to not talk about maybe a desire, but an actual action to do so. But I will defer to, certainly to Chair Bailey and the board as to how you want to frame that.
And sorry, both to Melissa and to Linda for referencing. So I guess back to my comment on your summary of what other states are doing right now. Obviously, they all have different approaches and different legislative requirements. But I guess I would just like to ask any of my colleagues here today, is there anything related to what Myers and Stauffer's helped us document related to those states that you would like to discuss? I guess I just, knowing we do have a lot to discuss, I guess I just want to reinforce that each of our PDABs are unique. Our legislative mandates are unique. Our approaches and what we're trying to achieve are all unique and different. So I just wanted to, I think these summaries were very helpful that Myers and Stauffer's provided for us, but I just wanted to make sure that, and I do want to recognize we did have additional support from Jane Horwath on these things as well. But Dr. Hoagland, you have the floor. Thank you for your question.
So my question is, was there any meetings between PDAP, different states, or was this strictly following the language in the rules?
Linda, would you like to answer that, Ralph, or I can
Sure, I can. I mean, I think this was probably to answer the specific question of dialogue. I would freely share that I communicate regularly with the executive directors and my counterparts in these states, and we all freely share information. In fact, our enabling legislation actually allows for data sharing of information with these other states. So did we engage them specifically on reviewing or finalizing the language in here for accuracy? No, but I would say this is all broadly, publicly and widely available information.
Right, exactly. Dr. Hoagland, the information is primarily from their statutes and regulations and certainly things that are known in the industry, and as well as some of Jane Horwath's work too, which is in the appendices or appendix that we have made to the report.
And I guess the other comment I might offer, apologies, is that knowing this is our audience is the legislature, the goal and intent is to provide a broad yet brief context of the entirety of the landscape of PDABs and upper payment limit kind of status reports. So I think it is brief but appropriate as a welcome and introduction to the issue for many legislators, that this will not be something that they have great understanding or context for.
Right. Okay. All right. So any other comments on the background, the landscape, the supply chain? And certainly around the public engagement efforts. So I have captured some of the comments on, or hopefully all of the comments on public engagement. Is there anything else that you all would like to discuss in these particular areas before we move on and just really jump feet first into the conversations around the plan and other parts that start around page 18 of the document? Okay, so Chair Bailey, I think we are ready to jump in and start the conversation. As you know, we did we did start to have some of these conversations in a pretty, I think, engaging and robust conversation last meeting to start to get into this discussion around potential methodologies, what the plan might look like, and as Ralph has said, and as others have said, it is a toolbox. We didn't exactly use those words, although it's a great concept. And I have been tempted many times to put a picture of a toolbox in the middle of the document, along with wrenches and hammers and screwdrivers and everything else. So it is intended. And we obviously are very immersed in this concept at this point in time. So I think one of the things that is very important to us as we as we move through this, as we discuss this, as we make changes to this document, is that you all are reading it. Really, you have your ideas, you know what you want it to say. This is an opportunity for you to see it for the first time. And if it's not hitting some of those points, for example, Mr. Judge, if you feel like there are things that need to be reiterated, for example, or more strongly, then we welcome those so that we can make sure that those comments get worked into the report. So with that said, I think let's jump in right here with the plan for establishing an Oregon specific UPL. These initial paragraphs are intended to be introductory, but again, as we've said all along, we would welcome any thoughts that you have about whether or not this lead in, these paragraphs establish the tone that you want to set. Do they get us where we need to be? Do they establish your message? And then we will jump in more detail with methodologies and implementation and that sort of thing.
And I guess one thing I want to clarify, I guess I alluded to it earlier, but just want to reinforce it now that we're into this section. While I have additional comments too, I do just want to reframe for everyone that the way I read the draft before us is that we are documenting a very flexible approach to doing things in different use cases, maybe for different drugs at different times. When we started this discussion, my personal opinion was that we were trying to achieve like a formulaic approach to doing things that was kind of uniform for everything. And the way I read this iteration of where we're at is that we are attempting our best to make things as flexible as possible for to help guide us through the future. So that's my personal lens that I'm reading this from, but I really welcome everyone else's kind of opinions about what you see when you look at this language.
And certainly you'll have, as we've mentioned, you'll have another opportunity to provide back, some inline comments or changes.
Mr. Judge, you have the floor.
Thank you, Chair Bailey. Just a question for the board and for Ms. Wyant in this first section. So, I know that this is leading us down a path where we get to consider different UPL models and their value. Do we think that in this front part, we should stress that any of these models, because it's going to be a toolkit, needs to consider impact on stakeholders, like consumers, payers, healthcare providers, the pharmaceutical companies that support, provide the medications. This is an ecosystem, as Chair Bailey has said, and I think we need to kind of be mindful of a UPL method that may be considered, and what impact it could have on the various stakeholders in this ecosystem, with the goal, of course, to ensure access and affordability for the healthcare system. I think just as we get into this journey, that needs to be something that we keep front and center as we do this investigation or report on this investigation. And it didn't quite jump out at me.
Okay. All right, yes, so we can certainly speak to that, add some language here in the opening section on that.
Yeah, and I could kind of make my comments in red lines too.
Sure. Okay.
To your point, Mr. Judge, I mean, during those constituent meetings, some constituent groups did express more comprehensive feedback related to, you know, how they envision things impacting them, whereas others provided less. But I certainly hear what you're saying related to that. And then just the reminder for all of us that this is our report to the legislature, and they may have their own opinions and guidance on, you know, what if they chose to pursue it, what that would look like. Dr. Hartung, you have the floor.
Yeah, I just need to be reminded, are we statutorily prohibited from considering any sort of metrics related to value, cost effectiveness, things like that, as it being potentially added to this toolbox?
There is no prohibition. The task is upon this board to come back with an implementation plan and methodology or approach. So to that point, Dan, if it's something in the value-based construct is something that you think should be in the toolbox, it's certainly within our purview.
I'd like to at least see some, there's some in like one of these in the table that has the different at least approaches. You know, there's a domain around it's like return on investment, basically. Find it here.
Melissa, that's on page 21 in the table.
Yeah, which kind of gets at in like kind of a clunky way, basically, you know, trying to line up drugs used towards a particular drugs used towards maybe saving money in other areas, which is I would say is a kind of a clunky way of getting at value, perhaps. And so I don't know, I fall in the line that I think that it's worthwhile to at least think about a drug's value using the different tools that have been developed and are used by the ICER group. They certainly have like cost per quality that they consider, but they have also developed other metrics that try to avoid a lot of the concerns about using qualities to assess value, right or wrong. So I think it's worthwhile to include that.
Sure. So Dan, if I may, just a couple quick things there. One, as I think likely understand and aware that there is a prohibition on us using qualities, I will tell you that as you mentioned other metrics, the staff and the Department of Justice are of the belief that the ICER tool, the estimated life year gained, is not something that would be prohibited. With that said, and you're speaking of the ROI or budget impact piece, the ICER tool, their budget impact modeler, does not even use the estimated life year gained in that calculus. So to that point, those all could be tools at our disposal. What I might ask of you is, I think based on your academic experience and knowledge and understanding and mastery of this, would be to ask you to take a little volunteer ownership of potentially providing the red line edits for this section and expanding this out based on your work and understanding, if you're open to that, so that we capture your spirit and intent of what you're talking about.
Yeah, no, I'm happy to provide that. And I support the budget impact approach that they use. I think that's valid, and I know that they have cost per life year and then a cost for equivalent life year gained as well, which try to circumvent this concern around quality. So I'm happy to add that as well.
So to
Great.
confirm, if I'm hearing you right, Ralph, then the payer return on investment row, is that the one, Dr. Hartung, you would be willing to kind of either help with language related to naming even the concept and some of the bullets or language within that specific section? Is that the part you were referencing?
Kind of. I mean, that my global question is like, are we even allowed to talk about value? And they it's in there in that box, and to what degree? And because I have opinions about it. So that was like part one, and then part two is I'm happy to provide suggestions in terms of maybe unpacking what's in there a little bit more based on kind of, I guess, my understanding of what we're allowed to do or what's council has said we should try to avoid, and what I think is reasonable in terms of just even providing options for us to think about as we again go through this process.
Thank you, because I think the answer to your question is yes. These are our general approach concepts for the legislature, and they're not mutually exclusive.
Okay.
Again, not with Ralph answering the policy questions, because of course that is not my my area of expertise. Robert Judge, you have the floor.
Thank you, Chair Bailey. Yeah, just to piggyback on what Dr. Hartung was questioning, and I wonder if this would be useful as we kind of tee up the UPL model section of this report. We don't make reference to what criteria should be considered to determining kind of a methodology. And I realize that each particular method is different. But there seems to me that it would be beneficial in this report for the legislature to at least have a sense of what criteria should be considered in this report, with goal, of course, of fulfilling the mission, which is to, preserve access to affordable medications for Oregonians. I wonder if there's some consideration, because it kind of, I think, piggybacks a little bit on what Dr. Hartung is hitting at, but at kind of much higher level. I think we're fairly silent on that in this document so far.
Robert, can you expand on that just a little bit? So I want to make sure that staff is tracking your ask, in that I want to make sure that what you're asking for isn't analog or exactly the criteria that staff and board will be looking at when we resume affordability reviews, if in fact those are the same kinds of issues, or if you're speaking of something more specific.
Well, let me try that, Ralph. So I think there has to be a rubric that we're thinking about that's consistent across any of these UPLs, and that a UPA model may address that rubric, which is, kind of, if it does improve access or improve affordability, how is it doing that? How is this UPL option doing that? We need to kind of establish what our criteria are that we're trying to use in looking at an ROI model, or kind of a WAC discount model, or a kind of a rebate model. What are we looking at in each one of those, with some specificity that it addresses whether it's improving affordability or improving access. And I know I'm on this theme today, but it's missing in this document, which is I think something we got to figure out how to call out in more than one place. So if I look at a budget impact based option like what's on the screen here, I'm not quite sure. I understand what the mechanics are describing, but I'm not sure as a legislator, how they would even think about that in terms of its helping us fulfill our mission of as a PDAB. So there may be, and I don't have the words right now, but there may be some high level, criteria, like first, do no harm. Don't disintermediate the supply chain, or maybe other kind of reconfigure the supply chain. Focus on the payer side. Don't focus on the supply chain. What are some elements that we're thinking about that helps us consider each one of these, or help the legislature consider each one of these UPL options. And when we say look at it this way, there's got to be a why related to it. So look at it this way. And I wish I was more formalized in my thinking right now, but this discussion, especially Dan's comments, really has kind of made me think about, well, there seems to be a gap in what we're talking about, because I'm not sure how any one of these would further our mission. They all might, but I'm not sure how.
Well, and Mr. Judge, thank you for that. With additional time to ponder, we'll have a 5-minute break to think about that. So I am calling a 5-minute break for the meeting. So we will, I guess, re-engage in our fruitful discussion at 10:52 a.m. Pacific. Welcome, colleagues. Melissa or Ralph or Courtney, could you guys confirm, did I say 10:52 or 10:53?
I believe you said 10:52, Chair Bailey.
Okay, well, thank you very much. I would like to confirm that we have maybe a quick roll call just to make sure we have quorum to proceed. Or
And board members, if you can just come back on camera and give a thumbs up, we will know that you are back with us. We see Lori waiting on Robert Judge, Dan Hartung. I see Dan Kennedy's thumbs up. I see Chris Lehman. Dr. Burns, are you back with us as well?
And we have quorum to continue our discussion if Dr. Burns and Dan Kennedy are not yet back.
Dan Kennedy is back. He did come on camera and then just went off. So
Is that quorum? 1, 2, 3, 5.
Yes, we do have quorum, Chair Bailey.
Great, let's go ahead and continue our dialogue. Linda, or I can't recall where Mr. Judge, I'm sorry, we did have to cut your discussion earlier. Mr. Judge, you have the floor.
Yeah, thank you for the 5 minutes to kind of congeal my thoughts. So
it was all for you.
So I'm just to kind of be a little more, Dan, I thought raised a really, really, really important point. And so I think as we go through this UPL discussion, we have to kind of look at a UPL option from the perspective of, is it addressing our primary goal? And we should probably kind of have that understood and known. Is it, maximizing affordability? Is it ensuring patient access? Is it ensuring that we continue to preserve innovation of the pharma industry? Is it a balance of these things? And it kind of having understanding kind of what our goal and the criteria would be, for example, is reducing out-of-pocket costs for patients more important than minimizing the impact on the pharmaceutical industry revenue. I mean, I think we need to kind of think about those things, or at least not think, but have some sort of discussion around that in this document so that we have a rubric around.
Robert, let me ask you Robert, let me ask you this question, and then would certainly love to hear from some members that we have not heard from yet in this discussion. The context that you noted earlier was very, very relevant, and that was be thoughtful of how you proceed, i.e. unintended consequences. Knowing that what you're suggesting here, I think suggesting on these approaches, the construct of getting pretty granular on some of those potential consequences might be both honestly a heavier lift or longer runway than we have to do. That could be a 6-month conversation unto itself, candidly. To that point, my question to you is, do you think that addressing these in a global context of the guidance or the memo or the beginning piece to the legislature, as you noted, of be mindful, here is a potential list of unintended consequences, or here are things that are cautionary or advisory in proceeding at a higher macro level, would convey that message with appropriate importance and significance versus trying to spend time and energy over the next 5 weeks getting into that level of detail with each of these?
Yeah, Ralph, fair point. We don't have the time to get to kind of what I was getting at. But I do think we need to call it out that, we have to make sure that an upper payment limit or limits recommendations kind of fit into some considered approach that, that the state can support.
And
Great.
I guess I would like to lean into what Robert is saying in reference that I think this document attempts to do some of that when you're looking at like pages 28 and beyond. But to your point, maybe those are sections that we could further enhance related to calling out what some of the unintended consequences might be. Dr. Hartung, you have the floor.
Yeah, I mean, I kind of see this table here, which I like, as, we're gonna, any particular drug, we're gonna think about, if we're considering an upper payment limit, we're gonna think through all these different frameworks for what it's like a number, an upper payment limit. It's gonna be, maybe it's gonna be $10, maybe it's gonna be $5, and it's gonna be based on all these different ways of thinking about, what does a VA pay for it? What is it paid for in the commercial area, net rebates? And so it's just ways of thinking about what this number is going to be. And so that's like thought process 1. And then thought process 2 is like implementation, and like, what are the consequences of an upper payment limit that could run between X and Y? And obviously, you could think about it in terms of like some of these longer term branded drugs in the Medicaid population, because of inflationary rebates, they're free basically. And so obviously using that model to select the upper payment limit in Oregon wouldn't be feasible, because, that would have pretty profound consequences for the system if you just say we're just going to apply the Medicaid rebate for the entire state of Oregon, if it's as basically as free. So I feel like we kind of I like to break things up, problems into pieces, and so this is kind of the first piece is like thinking about what could it be, what is it based on? Is it based on value? Is it based on budget impact? Is it based on what other payers are paying? And then part 2 of this is like, what are the consequences of setting a very low upper payment limit in terms of manufacturers, pharmacies, providers, patients, things like that. And that's probably, I haven't taken a huge deep dive into this entire document, but I know that implementation is further down, and there's quite a bit of discussion about like how this potential upper payment limit might affect all the stakeholders.
Well, and I guess along those lines, Dr. Hartung, I mean, because all of us with our different, professional background and more in-depth knowledge, I mean, maybe that's a task for each of us board members, is to write paragraph or something that maybe we could provide to staff about what would some of these potential unintended consequences, if they're not already addressed in this document, like what would they be, right? I mean, because this document's intended to educate and inform the legislature, right? I don't know, I'm just brainstorming, so, and I see that Chris has his hand up as well.
Thanks, Chair Bailey. I think I just, and I don't know if this is what Dan's getting at, but I don't know that we're going to know all of the unintended consequences either until we really start to delve into it. I think for me, when I'm looking from that page, sort of, I don't know what, I thought it was 18 or that in that 18 to 22 section where we're kind of talking about implementation and what it looks like, I would like just more recognition of the complexity of this whole process, because if there's a legislature or a legislator who is really naive to all of this and reads this and thinks, oh, you know, this sounds like a great idea, it's going to save a bunch of money, I want them to, at a really basic level, just understand this is so complex and we have a lot more work to do to really ferret out that this will even work and have the impact that the legislator is wanting, or the legislature is wanting it to have. There's just a lot more work that needs to go into it. So here's some potential options at a real high level. I think for me, at least, the table is good. It kind of describes what each of those potential options are, but just more emphasis on how complicated and complex this is going to be.
So Chris, that is excellent feedback, and we definitely can work with that. If I can just share with board, Chair Bailey and I did confer during the break. We are going to extend this part of the conversation, I think, Chair Bailey, till about 11:15 or thereabouts. So let's continue. And Chris, that is a great comment. Thank you. But can I take opportunity, and I don't want to call anyone out specifically, but those board members that we have not heard from during this conversation, anything specific that you want to add or contribute to this conversation, or that's lingering in the back of your mind, please bring it to the front and share. Thank you.
Dan Kennedy, you have the floor.
Yes, thanks, Chair Bailey. One of the things, and this may be partly due to my relative newness with the board, but I notice in one part of the document, it says that the board shall determine when a drug is unaffordable. So I'm curious, I haven't been through an affordability review, but I'm curious about the confidence level of our affordability reviews to say, this drug is affordable and this drug is unaffordable. Because it says it's up to the board to determine which drugs are unaffordable. And then in the event of an unaffordable drug, we might parlay any one of these mechanisms going forward. So sorry, it's a little bit off the UPL discussion, but it's just something that occurred to me.
Ralph, I don't know if you want to answer that or you want me to, but I mean, I think, Dan, you may be aware that we did pause the affordability reviews that we were working on in 2024 so that we could start the process in 2025 with more current and relevant information, as well as we have enhanced our team significantly related to data and analytics. So that is something I believe, Dan, just from my own personal understanding of things, is going to be what we are working on together as a board. So I don't have a yes, no, maybe some kind of answer, but that's part of the great work that we're all doing together.
Great. Thanks. Appreciate that.
Absolutely. But Vice Chair Burns, I believe I saw your hand raised.
I was just gonna, because Ralph wanted us to comment. I'm enjoying the conversation. I haven't had anything compelling that I needed to add so far.
So if Chair Bailey, if you don't mind, I'd like to go back to Chris's comment about stressing the complications and complexity. I agree with Ralph. That's super helpful. So is it Are you thinking more in the preamble, or is this something that you want to see fleshed out a little more in the table?
For me, it's at least I don't. Oh, sorry, Chair Bailey, am I allowed to respond?
Oh, yeah, absolutely.
I don't know the proper procedure.
You have the floor, Mr. Kennedy.
Oh,
Mr. Lehman.
Oh, Lehman, I'm sorry. I'm sorry, Mr. Lehman. Yes, you have.
At least for me, it would be more in that introduction or the establishing section. The table I thought was okay as long as it's orienting them to these are potential options. You know, we'd have to really. I mean, it's more in the beginning, and then in the implementation section and the enforcement section. I thought, especially around the enforcement section, I think it says like the program will run itself basically, but I think there's a lot more to it than just that opening couple of sentences that said, you know, hey, it's a self-enforcing program. This should run pretty smoothly. It's kind of, as a layperson, that's how I would have read that, I think. And that's not at all the case, I don't feel like.
No, that's
because in
good.
the next section, you go through all these things that you'd have to be able to enforce it. And that doesn't seem to align with 2 sentences that say it's going to sort of run itself.
No, great comment and feedback. Thank you. Can work with that.
Thank you, Chair Bailey.
Absolutely.
hey.
Dr. Hoagland, you have your hand raised. You have the floor.
So I guess kind of representing an opposite perspective is to appreciate the complexity, but also realize that we don't want to do analysis paralysis to a point where we don't have action and we don't accomplish reducing cost in a timely fashion.
Thank you for adding that reminder for all of us.
And Dr. Hoagland, to that point, is there something that you feel like needs to be stated a little bit differently, or is it really just more of a general comment?
Well, I think somewhere in the document we should call out the fact that we're kind of on balancing the complexity with the need for action. Because
I guess, and to your point, Dr. Hoagland, the need to provide this report to the legislature as requested.
Yes, getting it to good enough.
I mean, I guess, and again, if maybe my comments here will provoke all sorts of discussion from my peers here today. But, you know, one of the things I thought of in reviewing this document, and kind of to Robert's point earlier related to kind of trying to address and shine a light on potential affordability challenges at a very broad level. One thing that I, you know, have kind of been ruminating on and thinking about is, you know, related to a UPL, is there bandwidth and space in this document for us to provide, and again, I was going to mention this more in the legislative priority section of our discussion, but because we might condense that, I'll mention it here. You know, I was wondering if there's an opportunity for us to even add a section about what are some alternatives even to UPL, and would that be appropriate to add into this document? I know in constituent sessions, we asked constituents that, but I don't know, you know, if that's something that we would be able to have the flexibility on. If we do have that flexibility, then one of the suggestions I was going to put forward would be something more related to a pass-through savings model. So lots of states have pass-through programs that do pass-through savings for public employees and then add a minimum dispense fee. West Virginia recently came out with their report for public employees. And so again, it's a little bit off UPL, so I was hesitant on where I would mention it. But Kentucky, West Virginia, California, there's all sorts of these kind of pass-through models, and is that something we would also be wanting to share with the legislature as they review report, or as they review I guess ways to potentially encourage decreasing expenses. And I did assume that would create significant discussion, and now we have 3 hands. Ralph?
Chair Bailey, if I may, because some of this in my role, and if we can, I think we're going to be safe rolling till 11:30 in this conversation and discussion for folks. But to that point, I would say that our obligation is very prescriptive in statute with Senate Bill 192, and that is a plan for developing upper payment limits. With that said, in no way dismissive of the policy constructs and recommendations and ideas that you just floated. To that point, I would say that they're likely more appropriate as policy recommendations to the legislature. With that said, I probably should also say, I think as we get into this conversation and we begin to solicit red line edits, comments, and feedbacks from people, noting that the obligation, as we've already said, is to deliver this report to the legislature. That is not dismissive of the fact that every person here as an individual brings their own lens, perspective, attitudes, backgrounds, and approaches. So to that point, if there are things and we do not reach entire perfect consensus on everything, that is okay. And if there are board members that through their comments and feedback express concern, heartburn, whatever you want to call it, with any specific aspect or element of this work product and potential implementation strategy, if you will, that please, not discouraging you, emphatically encouraging you to capture and articulate those both today and in your red line edit document opportunity that you will have. To that point, if there are things that come up, I anticipate that we will frame those up in the narrative as something to the effect of one board member expressed concern about XYZ. Several board members expressed concern about PDQ. So we do not want to discourage you from expressing any concern that you may have. So I want to be very clear that we are affording you that opportunity to do that. But again, emphasizing the point that the obligation is to produce this substantial deliverable to the legislature to send in all of about 6 weeks now. Thank you,
No,
Chair.
I hear what you say. I guess I'm just referencing that since we asked constituents, if we have board members that want to enhance, not take away or detract from what was in the information related to UPL, that was the context in which I was sharing that.
I do, however, I want to say, though, that I think that because statute is prescriptive, that the ask is for an upper payment limit implementation plan, that those alternative modalities of lowering cost of drugs for consumers would likely be better shaped and packaged in policy recommendations.
All right. So I'm regrouping momentarily, so bear with me. Great discussion on this section. I think we have several takeaways that are very helpful. Is there a desire to perhaps move? We've talked about the table. We do have some specific recommendations on a couple of these. This particular, thank you, Melissa, table 2, the general concepts. Are there specific conversations, and Chair Bailey, or Ralph, does it make sense to maybe talk quickly through these or solicit individual feedback if there is any on each specific, I will just call it an option within the table. We did get through some last time and I think it was well reflected, but are there options in here that we did not discuss as fully that anyone would like to comment on specifically?
Mr. Judge?
Oh, yeah.
Just a general question on the last one, that 340B option. I know I spoke briefly about it last time, but I'm struggling to understand how this is an upper payment limit strategy. Because 340B is only available to a subset of healthcare institutions that serve, kind of a safety net population primarily. So I'm struggling with that, and I don't get it. Maybe somebody can help me understand.
Would it be something, and certainly we'll see if your colleagues have any thoughts. Is it something that you might want to see more reframed as an implementation consideration?
I think so, and I hope I don't offend when I say this, but I don't understand why it's an option, because I'm not sure who it benefits other than 340B safety net institutions, unless the objective is to ensure that safety net institutions can continue to capture spread based upon commercial payers, and we're concerned about driving their business model away. That's a crass way of saying it.
I cannot recall who had their hand up first. Lori, Dr. Hoagland, you have the floor.
To me, the 340B program looks at health equity and making sure that we're protecting some of the more vulnerable people in our state. So it is an important subset for that reason.
Hey, Dr. Hoagland, can I ask a follow-up question? I'm sorry, I don't want to play Perry Mason. I just want to understand your statement. I get the 340B program and the tremendous value it has. So can you tell me where your statement supports it as an upper payment limit thought?
And I guess I'll just add also, no board members need to feel obligated to respond if questions aren't questions that you feel comfortable responding to.
Mm-hmm. Fair point.
So I think Dr. Hartung had his hand up next. So Dr. Hartung, you have the floor.
Yeah, I read this. I read this a few times now, and the more times I read it, the more I'm a little bit confused. So I agree with Robert's comment. My initial interpretation of it was we would base any theoretical upper payment limit based on 340B pricing that that they are able to leverage, essentially, which obviously would have probably pretty big downsides for the 340B entities who, like you mentioned, use that spread to fund their kind of outreach efforts and things like that. So I guess some clarity, about what actually this concept involves. If that's indeed what it's suggesting it involves, then obviously I think all these have different downsides and upsides. And so I'm opposed to keeping it if that's what the intent is. I think it's fine to keep it as an option, but just obviously we need to recognize that there are potentially some pretty drastic downsides to doing that type of thing. So for the 340B clinics entities.
And Dr. Lehman, you have the floor.
Thanks, Chair Bailey. I think I had read it. I mean, now that it's pointed out to me and I read it a couple more times, it isn't maybe as clear as I thought it was, but I thought that the 340B specific part of it was creating some sort of adjustment for the 340B entities, Robert, so that they didn't lose as much as they potentially would have, kind of addressing all the concerns that we heard in the discussions from the 340B covered entities. But now that I read it, I don't think it's really clearly saying that. So I might have misunderstood what I was reading by that UPL adjustment for some or all 340B entities. I thought it was a way to address their concerns, but maybe it's not. We probably should clarify that.
Dr. Hoagland, you have the floor.
Well, clarification may be needed, but I do have working at a federally qualified health center in Southern Oregon. We serve a huge population in the southern area of our state, and unintended consequences to 340B programs is something that I feel is a concern, and so I want to somehow incorporate that in this.
Thank you, Dr. Hoagland. I guess I would follow up on Dr. Levin's comment that maybe the language itself, kind of hearing that maybe, Dr. Levin thought maybe we could wordsmith it a little bit. I think some of that comes to if we had a UPL authority, if that's something the legislature decided to pursue, that from my perspective, how we've written some of the potential ways to look at that would provide flexibility, because we've shared information with the board about a UPL that's kind of on the buy side. We've also discussed how there could be options where UPL mechanism is on a rebate level. And so I had thought, with my biased perspective, kind of with that knowledge, thinking that this language made it flexible enough that could be addressed depending on what the will of the board was and what the mechanism was, that could be years down the road or drug by drug specific. Mr. Judge, you have the floor.
Yeah, so I agree the language is problematic, and that's probably why I came at it this way. But if the objective is to establish a UPL that's predicated in some way, shape, or form on public health service 340B pricing or federal supply schedule pricing or VA-like pricing, then I could see how that can have a significant impact on affordability of drugs and potential access to affordable medications. That said, understanding Dr. Hoagland's comment about kind of the importance of the safety net and preserving the business models that they use so they can pursue their public safety mission is an argument against it. So maybe the description needs to be revised to really say what it's attempting to do, and then have in the bulletin comments to the right kind of beware what you can do, or for the safety net, because that can have consequences. Or if that would make sense to me.
So a general comment would be that my understanding was this particular option was indeed more of an adjustment for 340B entities, but certainly open to where you all would want to go with 340B program specific requirements. Does it even belong here, or is it, as I suggested, it could go into implementation, it could go into an unintended consequence discussion, it could stay right here too, if you have some thoughts about how to better clarify the language or guide it to something that is more meaningful. Certainly open to suggestions on how to do that.
I would jump in, Linda, and say I welcome hearing Mr. Robert Judge's response. I would want to be mindful of not deleting or voting on anything, because this meeting is not intended for a vote. So I would like to hear what Mr. Judge and others think about this section, knowing we are missing board members. I just don't want to unilaterally
Fair enough.
something when we don't have a fully seated board. So Mr. Judge, I apologize for interrupting before your response, but I wanted to make sure to mention that.
Fair point, Chair Bailey. If it's an adjustment, and that's prima facie, if that's what the language is getting at, then I don't think this is an upper payment limit item. I think it's a policy recommendation.
Dr. Hartung.
Yeah, I mean, I agree that it doesn't fit with the other things in this little table, and it probably is, 340B programs are like a stakeholder group that are affected by any sort of upper payment limit we derive and implement. And so I don't know, yeah, somehow interweaving it down below in the implementation piece might be where we want to go.
Mm-hmm. Mm-hmm.
Mr. Lehman, you have the floor.
Yeah, I think it's page 30 where the concerns were, and I think that for 340B entities, I think we could, change the wording in there to make it really clear the impact that UPLs could potentially have on, the FQHCs and the other covered entities within the state. I mean, just to make sure that we're calling that out, because I think we heard it loud and clear, right, Chair Bailey, in the listening sessions that you held with the FQHCs and the other 340B covered entities, that we'd need some sort of adjustment or way to either carve them out or address all that revenue that would be lost.
Thank you, Dr. Lehman. Mr. Judge, you have the floor.
I just want to say I second what Chris just said. Yeah, I think that would be where it fits.
And that kind of gets at what Dr. Hoagland's saying as well, I think, to really call out the concerns that,
Mm-hmm.
clinics like hers have.
Mm-hmm.
I guess the only thing I would say to add to that then is if that ends up being the will of the board to move the 340B kind of more line item inclusion related to the table that we have, I would again just reference my own comment that if we're kind of outlining some of these impacted stakeholders and plans, that knowing that what we're doing is very conceptual, I guess I personally would want to also make sure that my previous comments related to, are there other approaches that get us to where we can be related to cost savings, are also included as a paragraph. If we're keeping in mind impacted stakeholders that may not fit the exact mold of the UPL, then that's just my request that my information related to a pass-through with dispensing fee option also have a few sentences of space in the document.
Sure, Chair Bailey, I think that makes sense. As we get closer to time, and I know and appreciate that we've had great feedback from Chris and Lori, as we know that we will be sending out this for staff for board review and input, if we could make the ask of Chris and Lori to provide specific write-up or language on the 340B piece, and then staff will reconcile that and review and share that back with the board. I will say out loud and note that as a practical matter to the board and the general public, we are prohibited from collaborating together. I would not be able to meet with Chris and Lori to workshop something in the interest of time or advancing the goals and objectives of this board. That is unfortunate, but that is the reality. So we will work through these issues as we can individually and coordinate with you, Chris and Lori. But I would ask that each of you take that as a volunteer action item to when the document comes out. Chair Bailey and Linda, I will offer you just the last couple minutes, and then we will need to move on with the agenda.
Right. I was going to say, I know we're at time and we have a lot of important information to cover. So I think, Chair Bailey, I will just defer back to you as to how we might collect any further comments. I think enforcement is certainly I will just say to the board members, very important. Implementation considerations are very important. So we would welcome and look for any significant feedback that you all would wish to provide back to us in your inline comments.
Thank you, Melissa, for kind of visually going through this for all the board members here today. While it might just solicit someone's idea or comment that they wanted to make related to these sections. So I would like to kind of, Linda, kind of continue advancing this, at least hitting on the subtext for the next minute or two, so that we can get as much feedback as possible. Keeping in mind, this is a board report for the legislature, so.
All right, so quickly, I think we talk about enforcement and authorities necessary for enforcement. So if there's anybody who has a comment they would like to make, a suggestion they would like to make, we would welcome that at this time. If you found anything perhaps significant that you feel like needs to be added, that would be really helpful. And likewise, with the analysis of how UPLs could be implemented, if you have thoughts about things that might be missing or significant additions, that would be very helpful to hear those now, so we can try to get them incorporated.
And to Chris's earlier point, the anticipated or unanticipated, right? I guess what we don't know is more difficult to articulate. But to Chris's point earlier, with the expertise of all the board members here, you know, as those things that you might see could be logistical challenges that you can envision already, it would be helpful to hear that from members in the document, so we could incorporate. All right, well, I guess Ralph mentioned that we had until about 11:30 a.m. Pacific for this discussion. So again, Linda, thank you for helping to facilitate kind of going through this draft with all of us today. Again, I really encourage everyone here on the board to review the editable version that will be going out to members, and to, you know, really this is our report to the legislature. So to really, you know, take the time that you have available to provide feedback and notes will be very helpful in driving the final document that's provided to the legislature. So again,
thank you, Chair Bailey and Ralph for your help, and Melissa for driving.
Thanks, Linda.
Thank you. So we're now going to move forward to the policy recommendation portion of our discussion. Each year, the board sends policy recommendations to the Oregon Legislature. At the October 2nd meeting, the board began the discussion related to potential policy recommendations, and today we will continue the discussion. I do call on Courtney Whitlock, Senior Board Policy Analyst, to help start this conversation. Courtney, you have the floor. I am not sure how many minutes you now have given our amended timeline, but you have the floor.
All right, great. Thank you, Chair Bailey, and good morning, board. I hope everybody had the opportunity to review the slides. I did send to the board members just one updated slide yesterday, which we will discuss here more elaborately, but we will update the slide after the meeting, since it was so late in the day, of the correction of the one slide. So to get started, we had a can everybody see my screen first off? Okay, thank you. So we went over potential updates to the Senate Bill 844 that governs the work that the board does. At this time, I want to make sure I'm going to go through them, and then if we can have a discussion about what sections you really want to move forward as policy recommendations. If any slide or any suggestion of the recommendations needs further board discussion, we can continue that discussion for their next board meeting to shore it for the final version. I just want to make sure that I'm capturing all the essential, like, yes, recommendations over, so I can start developing the language to include in the final draft of the report. Anything else that's potential, we can have further discussion on, since we were kind of lacking in time. So the first portion of the recommendation, again, is around Senate Bill 844 cleanup. The first one kind of identifying from our first iteration of the board review that identifying 9 drugs is kind of challenging. So changing the language up to 9 drugs. Is this something that the board members want to have a discussion on, or is it something that the board members would also like to just add as an essential recommendation to move forward? Yeah, Robert, and you're on mute.
Just a question. So Courtney, are we soliciting for feedback? We're not making a board recommendation or voting on any of these at this point, are we?
No, we're not,
Okay.
we're not making any votes or anything. The intention is for the board to provide me with what ones that they do want to kind of for sure send forward as a recommendation so that I can start creating the draft language of that for your review next month to be finalized in December. If we don't agree on anything, again, I do have a little bit more time into next month. It just kind of presses up a little bit harder on the timeline, which is fine. You know, I can work through that. But I'm also happy to have, you know, meaningful conversations about what each of these recommendations are, even though we just touched base on them last month or last meeting.
So you're looking for the board to do kind of the Caesar up or down with the concept.
Yeah. If for just to kind of give me some guidance on like what ones I need to kind of focus on to to apply first into the draft to send forward.
Okay. Well, as a board member, I think this type of change makes a ton of sense given the fact that, you know, we struggled finding 9 in the kind of the first iteration of this effort. Being held to an absolute number is kind of a struggle.
Yeah, Dan Kennedy, I see your hand up.
Yes, I would just give a Caesar thumbs up to this concept as well. I think that gives us a much more balanced and yeah. So yeah, I think this is right on track.
Thank you. Any other feedback on this? Otherwise, I'll just take it as one to go ahead and move forward as a final one. All right. Thank you, Ward. So the next one is the recommendation to remove requirements that DCBS provide the board with a list of prescription drugs each calendar quarter. We've kind of struggled with this initially over the last year because there's been significant changes in manufacturer reporting to the drug price transparency program that feeds in the quarterly reporting for drugs on their increases of the specialty drugs. So, and one of the challenges is that when the information is submitted quarterly, then you're looking at drugs currently in the year, and our statutory requirement is to review drugs from the previous year. So there's a little bit of a misalignment of looking at drugs. We found that even though the manufacturer drug list itself is kind of challenging to analyze and create meaningful structure around, it's best to kind of do it in a lump sum for the year versus trying to stagger it throughout a year to determine where an impact is, because really there's not a whole lot of that we've been able to identify from the data perspective to make it meaningful. But I, you know, again, if you want more information about this, I'm happy to provide more information about this portion, or I can go ahead and put it forth as a recommendation. So yes, Robert.
So the practical effect then would be that if something happens in this calendar year, we won't see it until you do the next full year.
Yeah, and even at that, we haven't really identified any drugs currently making any current calendar impact. So, you know, again, we're just looking at best ways to utilize team time and, you know, making the data analytics really more meaningful in the long run.
Okay, that makes sense.
Any other questions from board members, or is this something that you want me to pass on or wait until for further discussion? Yeah, Amy, Dr. Burns.
Yeah, no, I think this is good. Anything that's going to give us some flexibility. We've done this now for a little while and we're learning. And I think that, at least from my position, the cleanup items all make a lot of sense and are based upon experience. So
all right.
I support it.
All right. I guess then hearing none, I will also move this one forward into the final. The last portion of this section, or the last recommendation for the Senate bill cleanup, is to remove the generic drug report from an annual requirement. this is one that we have had 3 reports on. We've learned a lot through the system, but the generic drug market doesn't change very much. I think that since we have an annual report around the affordability reviews that are done, that additional information that we kind of identify through the market is better placed in an annual report with the affordability review than it is to be its own, because or we need a little more guidance on maybe something else that legislators may want to see from the generic market. But as we've been doing this for a few years, we really haven't seen significant changes that we're trying to find meaning to provide for additional information. So, but again, I have to lean on the board's recommendations or your expertise in your field on, you know, is a generic drug report truly very meaningful, or is there a different indication that we should be applying to inform the legislators of what's going on in the market?
Courtney, the only comment, oh, Dr. Hartung, you have your hand raised.
So I think it's reasonable to kind of sunset these reports. And then we can just have a section in our annual report that summarizes at a really high level if there's big changes in the generic market, which, you know, there are some important things that are happening, but I don't think that, you know, the state of Oregon needs, and staff here need to devote time to kind of, because other people are doing it, you know, at a national level. We can kind of just pull that information and put that in a report that we find relevant for, you know, our annual report.
Robert, did you want to say anything? So you kind of, or are you just in agreement?
I was nodding my head loudly.
Okay. And Chair Bailey, what were you going to say?
Oh, I'm glad Dr. Hartung went first, because I was going to reference the importance of still keeping abreast on the biosimilar market, but I like Dr. Hartung's suggestion of just including the updates related to biosimilars in the annual report.
Okay, great. Then I will move all 3 of these to kind of the
Dr.
considerations and
Hartung.
then just update the language on them.
Dr. Hartung?
Oh, you're on mute.
Yeah, actually, that's a great additional comment that I didn't think about. That you know, with the biosimilars, that has specific state ramifications and implementation issues because of, you know, pharmacy law is different in every state, and so I don't know if you know, I don't know if just some sort of special attention to pharmacy law around biosimilars in Oregon might be a value added piece that could be included. And I don't know if we need to micromanage that into this cleanup piece, but it just, that comment resonated with me, so I appreciate that. I just wanted to second that.
All right, I'll see what I can do to
All right.
that recommendation into the report. All right, so I'm going to go ahead and take the 3 cleanup under SB 844, move those to the final version, or the draft version of a recommendation. So additional recommendations are around.
Hey, Courtney, I would like to interrupt you for a moment. I do think we're going to need to extend the meeting by about 10 minutes to afford all the time for public comment. Is that in alignment with what staff anticipate?
Excuse me. I believe Dr. Burns has a hard stop at noon. I'm not certain if we want to. I think we could probably go another 5 minutes with this, and Chair Bailey.
Yeah, so maybe, I guess I just want to reference, I'd like to keep 5 additional minutes so we can finish out.
Yeah. Vice Chair Burns, do you have any flexibility in your schedule? And I know we will lose our interpreter, as Rebecca is, I think, noting.
I've wasted 2 of those minutes just saying.
Okay.
I can hang out
Okay.
till about 10 after, and then I do have to go. I have something right after this.
Robert,
Okay, great.
And you're on mute, Robert.
I have to leave around 12:05.
Okay, thank you. Courtney, if you could proceed.
Yeah, and we'll touch base on these a lot more thoroughly. And then again, any board members who have any real heartburn on anything, please let me know so I can at least flag it for further discussion for next board meeting. But so here we have the patient assistant program reporting more to the drug price transparency program. Again, to kind of expand what manufacturer coupons and other payments that reduces patient out-of-pocket cost are. Another recommendation again is for PBMs and insurance to report on copay accumulators and maximizers. Does the board want to move either of these forward? One, both? Does any recommendations from the board?
I think we should. I want to make sure we're hesitant on not voting on including or excluding.
Yeah, I'm sorry.
So I don't feel comfortable asking the board that, but go ahead, Robert.
Yeah, I have a question, Courtney, on the copay accumulator question. My memory may be foggy, but didn't we have legislation in this last session where copay accumulators were disallowed?
Ralph, I may have to have you fill in on what that policy, I
thought it was HB 4113, if my
Yes,
notes are
and
familiar.
thank you and apologies. I cannot speak to this on the spot or eloquently for that. I apologize. I know there have been some changes. Let us go back to the well on this one and come back to you next month.
Yeah, I know there was an ERISA issue on 4113, but
okay, we will check that out. Thank you.
And Courtney, I will make a interjection that I think after this slide, maybe we won't do as deep of a dive in your other slides, and we'll save some of the other slides for our upcoming meeting.
Okay, that's fine. So then moving on, another recommendation is to uniform reimbursement rates for critical access pharmacies. Basically indicating that a uniform reimbursement rates for all claims of prescription drugs, whether it's fee for service. This ensures the payment priority for all payers when reimbursement per caps, and then a non-discriminatory reimbursement for all payers to adhere to the cap FFA, Medicaid, Medicare. Again, we can always bring this one back if more discussion. Okay. Around this one, around the CAA, the disclosures about reimbursement of fees to employer plans for brokers. I'm happy to bring this one back for discussion next month, unless anybody feels particular it should go into the draft report.
I think, Courtney, if we could allow a little more space for a more comprehensive discussion on these things in our next meeting. I just don't want to race through it because we have a ticking clock. But I appreciate you updating all of us related to this.
Yeah, so I guess the one that I just really want to call out, and again, this will be the slide that I had to redo to separate it out based on some feedback provided. So it has to do with the minimum dispensing fees across all payers. So before there was a lot of like overlap between the 2 points here. They were separated out, describing more of the minimum dispensing fees for all prescriptions, kind of following around like the fee for service program for the dispensing fee, and then a additional bullet where it prohibits the below cost reimbursement based off of a AAAC determination. So real quick, Dr. Burns, and then Robert, and then we'll.
Yeah, I think this is good. It makes a lot more sense now. I would say the title is still not accurate though, because we're not just saying the recommendation here isn't just a minimum dispensing fee. It's a minimum dispensing fee and reimbursement across all payers. So I would say if we're going forward with like putting this forward, we need to at least be accurate in what we're recommending, which is more than just dispensing fees.
Okay. We can do that.
But the body reads a lot clearer to me. So.
All right. Thank you.
And Robert, if you can keep your comment brief, we'll have a more detailed discussion on this piece in our next meeting.
That's what I just wanted to confirm. I think these really require some in-depth discussions. So I really want to make sure we carve out time and not squeeze it into the back end of the meeting.
Yeah. Hopefully next meeting we'll have a lot more time to go over these, and I'll save this one also for discussion for next month. So thank you, board, for at least getting the 844 cleanup stuff, I can work on that language and then we'll talk about this more next month. So thank you so much.
Courtney, thank you very much. Again, I do want to reinforce, I think, oh, Dr. Hartung, you did have your hand raised.
Yeah, I agree. We need more time. And also, like, are we going to be voting on each one of these as like an omnibus package for like, because some of them I don't, I feel like we may have diverging opinions about these recommendations, and the legislature seems to act on what we recommend. So I just want to make sure that we have a game plan for what's happening with this stuff.
From my perspective, one thing I think worked well for us as a board in the previous session, and I haven't talked to staff about this, was how we were sent like a survey of like priorities of them, and maybe with that type of survey method, like logic, we could all vote. I don't know. I think that my recollection serves me as that's what we did last time. Mr. Judge, you have the floor.
Yeah, I think.
And discuss, sorry.
Since this is a board recommendation, I really don't want to go on a plurality. I think we either have to think about it as this is what the entire board wants or the entire board doesn't want. That's just a personal opinion.
I personally disagree because there's some things we're working on that I dissented on that I have continued to work diligently towards. So I don't believe we need consensus, but I do believe we need to vote.
And we can apply the voting model because we will have to vote on the recommendations next board meeting. So we will have to allot more time for this discussion.
And Courtney, if I can real quick, just to answer Dan Hartung's question, it will not be an omnibus vote, all or nothing. They will be line itemed, if you will, individual issues, thumbs up, thumbs down votes. And Vice Chair Burns.
Yeah, maybe we should vote on how we want to vote on them.
Certainly could.
If we want to have be a complete board, or we want a consensus.
Certainly could.
Okay, well, we are going to now move into our remarks and public opinion. So I do want to announce that our next board meeting is on November 20th, 2024. And I do want to ask staff, do you have any announcements? Hearing that there are no announcements from staff, I'm going to move forward into the public comment portion of our agenda. The board received 6 written comments, which are posted on the board's website and reviewed by the board. We also received 4 requests for oral testimony. I'm going to now reference the 6 individuals and organizations that provided letters, written comments to the board, and then I'll read in order the speakers who will be providing comment today. So related to the letters that were received and provided to the board, also listed on our website are let's see, the HIV and Hepatitis Policy Institute related to legislative recommendations, the Community Access Network related to recommendations for the October meeting, Johnson & Johnson Healthcare Systems related to UPL, Pharma related to the October 16th meeting, Partnership to Improve Patient Care related to the UPL plan, and Regents Blue Cross Blue Shield related to proposed policy recommendations to the legislature. So moving into the 4 individuals who requested to provide oral testimony, I will call on each person who signed up and ask them to provide their name as well as the organization they represent. Each of these speakers has 3 minutes to speak. The board will not deliberate on issues or requests during this time. I'll also announce my phone is locked, so if someone else can please help me keep track of the 3 minutes. So the first individual who will be signed up to speak is Terrell Sweat from Johnson & Johnson related to upper payment limits. Terrell, you have the floor.
Hello, my name is Terrell Sweat, Director, U.S. State Government Affairs for Johnson & Johnson. Thank you for the opportunity to speak. As the board prepares the report for the legislature pursuant to SB 192, J&J respectfully requests you to first acknowledge the findings within the Myers and Stauffer report, specifically that a UPL is unlikely to result in cost savings. Second, recommend against establishing UPL authority. I'd like to highlight 4 findings from the Myers and Stauffer report as detailed in our written comments. First, not only could a UPL fail to lower patients' out-of-pocket costs, but it could actually increase costs for patients. The report concluded that pharmacists could be under-reimbursed and may have to shift costs to patients. Therefore, a UPL is unlikely to benefit Oregonians. Second, a UPL could negatively impact patient access to medicines, creating potential disparities for Oregonians. The report noted that pharmacists and wholesalers may choose not to stock or dispense products subject to a UPL. In rural and underserved communities, this could exacerbate pharmacy deserts for patients. Again, a UPL is unlikely to benefit patients and residents. Third, a UPL may not provide cost savings to the healthcare system. The report states that PEB and OEB could lose upwards of $8.9 and $3.1 million respectively due to lost rebates. The report made similar conclusions about OHP, fee-for-service, and the CCOs. Essentially, the more the UPL reduces rebates for the state, the less likely it is for these programs to achieve cost savings. This is true for a net rebate model, a maximum fair price model, and any other UPL model. As such, a UPL is unlikely to benefit state and local governments. Fourth, a UPL is likely to harm pharmacists, healthcare providers, and others in the healthcare system. For example, the report notes that pharmacists could operate at a loss, which could result in more pharmacy closures. It also states that pharmacists and providers may face challenges implementing a UPL. In sum, a UPL is likely to have unintended consequences for other entities throughout the supply chain. Importantly, the report validates what the board heard in feedback from 7 diverse constituent groups over the past few months. All 7 groups reiterated that a UPL would likely cause harm across the healthcare system. Yet, it appears the constituents' concerns are being ignored in the UPL draft board report for today's meeting. We ask you to take these concerns seriously. At J&J, we know that Oregon patients are counting on us to develop and bring to market accessible medicines. We live this mission every day and are humbled by the patients who trust us to help them fight their diseases. Thank you.
Mr. Sweat, thank you for your comments and thank you for staying within the time limitations. Next individual who has the floor to present is Daria McGrew from Pharma related to the October 16th, 2024 meeting. Daria, you have 3 minutes and you have the floor.
Okay, confirming that you can hear me. Aha.
We can hear you now. Welcome to the meeting.
Okay, thank you, Chair Bailey, members of the board. Two things that I wanted to address in my minutes today regarding the PBM data at the top of the meeting. Appreciate that the state of Oregon is now taking a closer look at PBM revenue transparency. The sunshine is needed to understand all the companies and factors and stakeholders that are driving prescription drug costs in the supply chain. It's a step in the right direction. Look forward to seeing future data that will be collected. We know PBMs are increasingly shifting revenue model to novel fee structures using GPOs, PSAOs, dozens of other fees that they can claim are not rebates and shield from reporting. Research shows that the share of PBM profits from fees has gone up by more than 300% over the last decade and is the fastest growing share of PBM profitability. But really appreciate the questions of the board members today. Setting aside this fee shape shifting, the data does highlight that patients are not directly benefiting from the rebates. Net prices of medicine are flat and rebates are rising. If nearly all of these rebates truly are going back to the health plans, then why are they shifting so much drug costs back to patients through increased coinsurance and higher formulary tiers? Secondly, regarding the UPL study, as our letter highlights, we will be submitting a more comprehensive analysis prior to your November board meeting. We really take issue with the board's ongoing practice of only allowing 2 or 3 business days to analyze and respond to meeting materials. These reports become increasingly weedy and substantive, and stakeholders need time to meaningfully comment. This practice of the board of these materials amount to a rule under Oregon APA and should be subject to notice and comment periods as prescribed in Oregon law. Generally, in your discussion of keeping the study high level and conceptual without any specificity, you don't know if any of these models are actually workable. Stakeholders need to be able to comment on real details. What you have here so far is a list of theory with a lot of risk and no proven benefit. If you can't get into the details of actual effectuation and then do realistic modeling, then you have no way of knowing if it is workable and if there will be any benefit to Oregonians. We will be submitting further detail on that later, as I said. Thank you very much.
Ms. McGrew, thank you for your comments and again for keeping the time in consideration. So the next individual who has signed up to provide oral testimony is Lauren Sant from the Caring Ambassadors Program related to board process and and dispensing fees. Welcome, Lauren, and you have the floor.
Thank you all, and thank you, Chair Bailey and members. I'd really like to thank you for the really thoughtful conversation that you all had today on the complexity of this issue and the consequences for the whole system. Really appreciate that. And the confusion about if we can't figure out what's affordable, how do we set up a UPL? I think we really need to understand how we get to affordability first. Also, thank you for the advisory board suggestion. Yes, you need a stakeholder advisory board. Happy to help you guys figure out how to make that happen and to get the right information from the patients. You know, as advocacy groups, we are more than happy to help you gather the right information that you need to make decisions about affordability. And copay accumulators are banned in Oregon as of the last legislative session, so I'm sure you guys will change that language. But just a last thought, if PBMs are putting pharmacies out of business, and one of the ways you guys are recommending we change that is to add a dispensing fee, then it should not be upon the consumer to put the pharmacies back in business. PBMs have to absorb that cost. Whatever language you put forward really needs to be clear that the dispensing fee is part of network adequacy and should not be passed on to consumer. In the PBM work group, it was very clear that the PBMs were saying they were going to just pass this on, and the insurer said they'd pass it on. It cannot be paid by consumers in Oregon. A dispensing fee would not be fair to patients. So that has to be part of network adequacy. And I'm just hoping that your language that you include will be really clear to the legislators about that. So thank you very much. Really appreciate all this. And I'm sure we have a lot to talk about in the future moving forward. Thank you.
Thank you, Lauren. Next, we have Mr. John Cavello from the Independent Pharmacy Cooperative related to board policy recommendations. Mr. Cavello, welcome. And as a reminder, you have 3 minutes.
Thank you, Chair. Thank you, members of the board. I really want to focus on this whole section dealing with minimum dispensing fees. I agree. It really has to be based on an alternative policy to have an effective UPL. And I want to focus my few minutes on, I know we've testified in the past in previous listening sessions. What's not been focused is on how this has to be a pass-through. In states that have done this and in payer groups that have done this, it's really about not looking at one part of the equation, but looking at the whole calculus. I want to really focus on, you have to look at this as a totality of payment, and that all the PBMs can then pass through to the end payers. The idea is to preserve access by paying at cost, but it eliminates the litany of actions that governments have been taking against PBMs that has led to overbilling, which is many ways you can measure spread pricing, both at point of sale and in post-claim adjustments they make. I would also really strongly suggest, and I'm happy to submit this to the board in writing, evidence of states through Medicaid managed care reform and state statutes for both the commercial sector and their public employee sectors of where they've used these as pass-throughs. And those government entities, not me or anybody else from a stakeholder group, has documented over $2 billion in savings. Just this past week, you may be aware, the state of West Virginia Public Employees Insurance Agency, for their public employee system, documented that changing to the NADAC cost plus, even with the higher dispensing fee, they are booking a savings of $2 million. There are 5 or 6 states that have done this in the Medicaid program. I would also direct you to your own Secretary of State's auditor report of PBMs in the Oregon's Medicaid managed care space. And one of its recommendations was going to this kind of cost-based, transparent pass-through model. The enforcement and the accountability is important, that the PBMs cannot charge any payer more than what it really costs. And that's how all these issues you're grappling with. How do we reduce costs of patients and the cost of sponsors while preserving access and including a pharmacy network is being achieved in many payment areas for you to look at. 3 states right now, West Virginia, Kentucky, and Tennessee, have this apply to all payer programs, public and private. So, Madam Chair, with recognition of time, I'm happy to continue to provide information to the board, but I strenuously recommend that you and Myers and Stauffer, and I know there's a lot of expertise in Myers and Stauffer on these models, for you to look at how they're being implemented and the program evaluations of how they're working to actually save money, which in the end does save end to the end payer. Thank you.
That's 3 minutes.
Thank you, Mr. Covello, for your comments. So with there being no further business before the board, all in favor of adjourning the meeting, please say aye.
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 Any opposed, please say no. All right, well, with that, the meeting is adjourned, and I'll remind everyone our next meeting is on November 20th, 2024 at 9:30 a.m. Thank you, everyone.
Thank you.
Thank you.
Thank you.